organizers for inviting me to give a talk on HIV and COVID-19 co-infection. There were some conspiracy beliefs on both diseases, starting with the origins of the viruses, both created in the laboratory. Both are alien microorganisms, or they even don't exist. There was a medical mistrust and even a lack of confidence in the medical staff. COVID-19 is a hoax. 5G is the killer. There is also an emerging evidence of stigma and discrimination related to COVID-19 pandemic, as it was for HIV. At the beginning of the HIV pandemic, it was called the gay plague or GRID, gay-related immune deficiency, as SARS-CoV-2 was named the Wuhan virus or the Chinese Kung Fu virus. There are a lot of psychosocial implications and fear and anxiety related to the transmission of both diseases. Medical staff is working in the HIV field and also in the fight against COVID-19. Testing is essential in limiting both diseases and the effects of the disease. There is an immediate impact and is more obvious for COVID-19 and the long-term social and economic impact for both diseases. Infection with SARS-CoV-2 is assumed to function in tandem with multiple other health challenges faced by people living with HIV, including chronic non-communicable diseases, mental health services, substance abuse, and other infections. HIV and other medical comorbidities may function synergistically to fuel COVID-19 disease in a syndemic and to produce increased burden of disease in a population. There are important, well-described risk factors for COVID-19, as older age, above 65 years, male gender, chronic lung diseases, cardiovascular diseases, and especially diabetes and obesity. A recent study that was presented at CROI this year showed that people who initiate antiretroviral therapy with a CD4 cell count of over 500 have the same life expectancy as individuals without HIV. There is a persistent gap related to comorbidity-free life expectancy, 13 years in people living with HIV compared to 29 years in people from the general population. Here it's a very busy table with the retrospective publication on key series in people living with HIV with COVID-19. And they were published in Wuhan, in Spain, in Turkey, Germany, Italy, and in the United States. And all of them showed that there is no significant difference in adverse outcomes associated with HIV infection for hospitalized COVID-19 patients compared to similar control groups. And here you see that in the first 6 months of the pandemic, there were 422 cases that were published, and most of them were male gender and had comorbidities. Other 3 studies published from UK, China, and United States in the last 2 months showed similar data that HIV co-infection does not significantly impact the presentation hospital course of patients infected with SARS-CoV-2 when compared with matched non-HIV patients. But a study from China reported a delayed viral clearance of confirmed COVID-19 cases in people living with HIV that was 30 days compared to 20 days in those without HIV, and also that there is a lower level of IgM and IgG antibody levels in patients with high HIV viral load. Another study that was performed in the United States, in New York, on 21 cases, showed that outcomes may be worse in HIV-positive people, as there is a greater percentage of HIV patients that require ICU, mechanical ventilation, or even died. And the rate of mechanical ventilation in these patients was higher than in non-HIV patients, and the rate of mortality was higher, 28.6 in HIV versus 23.8 in non-HIV patients. So the HIV status did not significantly impact clinical outcomes in patients with SARS-CoV-2 infection, but there is a greater percentage of patients that require ICU mechanical ventilation. But these results were not statistically significant. If we look at the characteristics and the analysis of risk factors for COVID-19 deaths in Western Cape, this study was presented at the Virtual AIDS 2020 conference. We can see that a greater proportion of COVID-19 deaths were in patients aged below 50 years and in those with HIV compared with those without HIV. And that current and previous tuberculosis were more frequent in people living with HIV, irrespective of COVID-19. A higher proportion of COVID-19 patients that died with HIV had current or previous tuberculosis. As you can see here, there is a difference of, from 14 to 37%. The increased risk of COVID-19 deaths in people with HIV could be overestimated in this study by some residual confounding as such as socioeconomic status and comorbidities. Patients with uncontrolled HIV infection seems to be more vulnerable to SARS-CoV-2, especially in the presence of comorbidities. And here we have the situation in our hospital, in Dr. Babeș Hospital, where we have an active follow-up more than 2,200 patients. And in this cohort, we had 8 cases with HIV COVID-19 co-infection. This is a cumulative incidence of 0.35. But I think that it's possible that we missed some cases as antibody testing is not yet a routine in our HIV-positive patients. Most of our patients were young males with a median age of 39 years. 2 were injecting drug users with chronic hepatitis C. 2 were with diabetes and hypertension, 2 with previous psychiatric disorders, and 1 was with a chronic kidney disease on dialysis. The median CD4 cell count at admission was 600, and 5 had a viral load below 50. 1 abandoned treatment, and 1 was an injecting drug user that never started antiretroviral treatment. Other characteristics were that they had 5 of them had typical COVID pneumonia. They were treated, 2 of them were treated with integrase inhibitor, 2 of them with protease inhibitors, and 1 had the combination of protease and integrase inhibitors. They received the combination with hydroxychloroquine and azithromycin, or only hydroxychloroquine. These patients were treated at the beginning of the epidemic, and we still use this combination. We saw that the negative swabs, the median time to the negative swabs was around 10 days, and the length on at the hospital stay around 10 days. No one was admitted in ICU, and we have no patient deaths. The last version of the EACS statement, released in August 2020, mentioned that there is no clear evidence for a higher COVID-19 infection rate of different disease course in people with or without HIV. However, most of these cases were reported in younger age and in patients with a lot of comorbidities. If we look at the role of antiretroviral therapy in people with COVID-19, there are two published randomized clinical studies on lopinavir-ritonavir. First of one in mild and moderate COVID cases on 34 people that received lopinavir and 35 that received Abidol. And as we see here in the table, there were no difference in viral clearance in these patients compared to control group. And if we look at the second randomized clinical trial that was published in New England Journal of Medicine on 99 patients on lopinavir-ritonavir, we can see that here in the Kaplan-Meier curve that there was not really a clinical benefit in patients that received the lopinavir-ritonavir. If we look at this table that showed the reported risk in 10,000 people with COVID infection related to hospitalization, ICU admission, and death, we can see that after standardization to age and sex distribution in this population from Spain, we can see that in positive person that the rate of death was 3.7 compared to 2.6 in the overall population, and that the risk of COVID-19 diagnosis and hospitalization was greater in men than in women, and also in the age group above 70 years, over 70 years. HIV-positive patients that received a combination of tenofovir, disoproxil, and emtricitabine have a lower risk of COVID-19 diagnosis and related hospitalization than those that received other combination of NUCs. But the number are relatively small to have final conclusions. If we look at the impact of the COVID-19 pandemic on HIV, we can see that there are a lot of challenges, let's say, that because HIV words were changed into COVID-19 words. There is a limited possibility of monitoring in these patients and less appointments, and therefore adherence in these patients may be diminished. Labs were repurposed for SARS-CoV-2, so the number of viral load testing and the CD4 cell count is decreasing. There is a reduced number of HIV testing, and this can have an impact on the 1919 targets, the UNAIDS targets. There is also a difficulty in hospitalization because these patients develop a lot of complications, and it's difficult to admit them in infectious disease hospital because now they are treating only COVID patients. Also, the current quarantine and the delayed art in some cases can increase the risk of complication. And also social isolation and depression and the mental health problem are increasing in this period. Scientific research on COVID-19 was accelerated, but this was detrimental to quality, and also detrimental to scientific research on HIV and clinical trials that were disrupted, and also on academic and clinical activities. Everything was in virtual format. It was an advantage, but also a disadvantage for example, for medical activity, for clinical activity for the students. What should we do to prevent disruption in HIV care during COVID-19 pandemic? We have to be centered on the patients still center, and we should use telemedicine, communication by phone, virtual and phone visits, to provide to these patients antiretroviral therapy for at least 3 months, to provide home care delivery for special categories of patients that cannot afford to come to the hospital, to work together with the NGOs to continue the harm reduction programs and opioid substitution therapy programs. And finally, antiretroviral therapy must not be interrupted in these times. We don't have to switch to boosted PIs and avoid we avoid unnecessary switches. We have to minimize the number of hospitalization and monitoring in patients that are stable. But we have to be careful on opportunistic infection prophylaxis that is still recommended in patients that have, because that in COVID-19 we can have severe lymphopenia. We have to vaccinate against flu and pneumococcus and ensure that we have for this patient and social and psychological support and even psychiatric treatment if needed. We have to work on mobilizing the community to prevent the spread of both infections. And finally, the key messages of my presentation are that patients with HIV infection don't seem to have a higher risk for acquisition of SARS-CoV-2, and they seem to have clinical outcomes that are similar to the general population. There are no proven clinical benefits for using HIV protease inhibitors. The COVID-19 pandemic has a negative impact on the management of HIV-infected individuals. We have to implement the implementation of quarantine and social distancing and other community measures, reduce access to HIV routine testing. And this is a big challenge for completion of UNAIDS 1919 targets globally. And we have to work on intervention to prevent disruption in HIV care. I want to say thank you.